Okay, if I can ask everybody to convene. All right, we'll get going. So good afternoon, everybody. For those who I don't know and those who are live streaming, I'm Sandro Galea, and I have the privilege of serving as Dean of the School of Public Health at Boston University. So welcome to this event. So today is the latest in a series of 4 we host throughout the year. At these events, we usually welcome speakers who address issues relating to public health. Our goal is to have their voices help us better understand the social, economic, and environmental conditions that shape well-being. And we value our speakers in the best of times and even more in moments of crisis. Now, few could deny that the opioid epidemic is such a crisis. Last year, about 64,000 Americans died from drug overdoses, with opioids often the cause. In Massachusetts alone, 38 people per week died from opioids last year. Tackling this problem has led to promising strategies and unexpected difficulties. We were exposed to some of them last week when we hosted the U.S. Surgeon General Jerome Adams and the Massachusetts Public Health Commissioner Monica Burrell. Naloxone, for example, has the power to revive some who have overdosed, potentially saving many lives. I have written about naloxone over the past 15 years, as have many others who are also in the room. But some have also suggested challenges with naloxone's use. Solving the opioid crisis, solving any public health problem for that matter, means dealing with conflicting attitudes towards a given solution and navigating the ambiguity of sometimes uncharted territory. Dr. Sally Satel is here to help us guide us through this territory. She's a resident scholar at the American Enterprise Institute and a consulting psychiatrist at Partners in Drug Abuse Rehabilitation and Counseling Clinic. From 1993 to 1994, she was a Robert Wood Johnson Policy Fellow with the Senate Labor and Health Resources Committee. Her recent book, co-authored with Emory psychologist Scott Lilienfeld, is called Brainwashed: The Seductive Appeal of Mindless Neuroscience. We have invited Dr. Satel to address one of the dominant public health challenges of our time and to expose us to perspectives that may challenge how we typically view the opioid epidemic. I have written in previous Dean's notes that it's important for schools to engage with such perspectives and provide space for complex competing ideas. When Dr. Satel finishes her talk, I would invite, and Dr. Satel would welcome, comments and questions. In keeping with the format for these events, as always, our goal is to inform discussion and debate to collectively sharpen our thinking around the issues that matter most to public health. On a personal note, Sally and I have known each other for a long time. We have intersected professionally for almost 2 decades. We have disagreed frequently and also agreed sometimes. But through it all, I have always admired Dr. Satel's clarity of thought and the challenge that she frequently poses to received wisdom. I have learned from her in the past, and I'm very much looking forward to learning from her today. I'm very pleased to welcome Sally Satel. Sally.
Thank you, Dean Galea, for such a lovely introduction, and also for having the Surgeon General as my warm-up act. I did watch that. It was very interesting. So now you have opioids 2 weeks in a row. Okay, I'm going to stand here, and you mentioned I was at the Partners in Drug let's call it PIDARC. Anyway, that's a methadone clinic, so I work there part-time. So I'm going to start out with some basic epidemiology because I'm at a School of Public Health, then move on to some history, the how we got here story. A lot of it will probably sound familiar before I get on to the areas that Dean Galea seems to think are going to be so controversial, and maybe they are, and maybe they won't, and that's all great. And then suggest some remedies. There is no solution, no one answer, of course, and we'll never get rid of addiction. It's ridiculous. It's a human condition. So, but hopefully we can, arrest the progression and reduce a lot of what President Trump would call American carnage. So, okay, first slide. As you can see, this is just to establish that the problem continues to get worse, drug overdose deaths. I'm a little more comfortable looking at them in terms of actual numbers. And so as you can see, the average, this isn't portrayed on here, but the average death rate is about 12 per 100,000, 42,000 people in 2016. Those are the last data from the CDC. But there's a lot of variation. In Nebraska, I think there were maybe 5 out of 100,000 last year, or again, 2016. And in West Virginia, I think it was 42 per 100,000, Ohio 39 per 100,000. So there's regional variation, as you know. And over the last 2 to 3 years, the picture has really been dominated by fentanyl, which is a synthetic opioid. Certainly it's used in hospitals. I'm sure you all either had it or administered it or know of it. It comes in patches for outpatient application. And when you have surgery, it's often the thing that's in the pump. And it's really good. But illicit fentanyl comes from China predominantly. And the main way to address that from a supply reduction side was through the public postal service, apparently, and also FedEx and other package delivery. This is a familiar slide to you, but you can't drive this one home enough, which is the relative potencies, why fentanyl has really, in some ways, really changed the landscape of this problem, because it's so deadly. So you can see there's heroin, and fentanyl is estimated to be between 50 and 100 times more potent than heroin, and you can see because of its potency and because it's so small, that makes it so easy to traffic, and it's a dealer's dream because you just put a little in and you've increased the potency significantly. Then there's a drug called carfentanil, which is has no application in humans at all. It is about 1,000 to 5,000 times more potent than heroin, and it's used mainly by game wardens and zookeepers. So it's an animal tranquilizer. But you can imagine when it gets into human bodies, and it's floating around in some communities, but fentanyl is by far the most common of the synthetics. Heroin is a semi-synthetic, and yeah. So yes, fentanyl is incredibly. Oh, I know what I wanted to say. That at least east of the Mississippi, almost all heroin is contaminated to some degree with fentanyl. And again, more numbers, about 2.5 million people are considered to have an opioid use disorder. These numbers are really not reliable. I mean, we all have to depend on what we get out of SAMHSA and or the NSDUH, National Survey of Drug Abuse and Health, and also from the CDC. But when you knock on doors, when your strategy of data collection is to knock on a door and say, "What are you using?" You can imagine you're not getting a good picture, a full picture of all the heroin and fentanyl use in this country. So I suspect it's higher than the 2.5 million. And there have been instruments that were used before that got into the jails and prison systems more effectively, but they were defunded. Hopefully they're coming back at some point. So how did we get here? Here, meaning here. I put the slide back up just to show some temporal markers. Most of these slides start in 1999. That's when the CDC's, if you go into the Wonder database, you can go farther back, but 1999 is when they present most of their data with respect to the opioid crisis. So, you've heard this before, quadruple, now probably between 4 and 5 times the death rate is in 1999 from opioids as there are today. But it kind of started, of course, before 1999, and it started before OxyContin, which was available in 1996, and it probably started, what do I mean it? I don't think anyone disagrees very much with the idea that where we are today was kicked off by over prescribing of prescription painkillers. Where we are now in terms of deaths is clearly driven by fentanyl and also heroin. And in fact, nationally, 75% of deaths are attributable to each. And I say attributable because when you look at the autopsy results of people who are said to have died from fentanyl or heroin or painkillers, you usually don't find just that pure substance. You'll find benzos, a lot of benzodiazepines in there, like Valium, Xanax, actually cocaine. But fentanyl, heroin, and benzos are often the combination, and pretty deadly ones at this. Often people wouldn't die from any one of those drugs alone, with the exception of fentanyl, but together you get a very deadly synergy. Anyway, so back to the time before 1999. So starting in the late 70s and early to mid 80s, there were a number of physicians who were becoming very vocal about the fact that we were undertreating pain, and there's no question we were. Demerol, meperidine was the major opioid of some morphine too, but it was typically underdosed terribly. And this is inpatient. This isn't even outpatient treatment, just inpatient treatment. There were a fair amount written about the undertreatment of pain, again, of people in a hospital, and some of them even with cancer. And so between doctors and patients, a movement to be more responsive to pain took off in the mid-'80s, and by the time and grew through the 90s, and by the time we hit around the early 2000s, the American Pain Society had successfully lobbied to have pain as a fifth vital sign, and the Joint Commission on Hospitals and CMS had doctor satisfaction ratings that depended on whether a doctor, how well he or she treated pain. And as you clinicians among you know, it takes 5 minutes to write a script for Percocet and 30 minutes not to. You can get in, it takes a lot of time to talk to people about other ways of dealing with their pain. So just going back to the 80s for a minute, I can't help but show you this, because one of the more vocal voices, and one of the more insistent voices to liberalize pain treatment was none other than our friend Marcia Angel, who I emailed with recently, and she still stands by this, and she should stand by this. You can read, obviously, the treatment of severe pain in hospitalized patients is regularly and systematically inadequate, and misconceptions have led to rather ritualized use. Now, what I mean by she stands by it is not that people are undertreated for acute pain in a hospital setting. That's not what she means. But where she goes on in this article is to talk about the classic opiophobia, which is that term coined by John Morgan, who was a pharmacologist at City College, and this was the idea that doctors were afraid to prescribe because patients would become addicted. And I can't help but think that was coming off of the heroin epidemics in the 70s. Draw the conclusion people are taking opioids, they're addicted to opioids, opioids are addictive. Well, of course, opioids are addictive, but how addictive are they in the acute setting? I'm going to get back to that, but I would argue that in many quarters, the addictiveness in those settings is highly overrated, as Dr. Angel was saying back in the 80s. But the pendulum did swing too far to the other side. There's no question about that. Doctors giving a month's worth of pills when either none or a few days would do, and aggressive marketing by drug manufacturers. And as I mentioned, the incentives that doctors had to prescribe. If you're time limited, it's easier. If the patient satisfaction ratings are important to your dean and to your hospital administrator, that's important. Those are pressures on docs. And it's true, a lot of them probably weren't as well trained as they should be in the administration of these medications and this. And then in some places, now we're in about the 2000s, okay? So in about the mid-2000s, more opioids, more heroin was coming in from Mexico, but also these pill mills were dotting the Florida landscape, and there were some in Kentucky and Ohio, and they were basically legalized. I guess you could argue we already tried to legalize heroin because that's what they were doing. This was pills for cash, and these clinics were, they did have doctors with licenses in them. The doctors who were quality doctors saw what they were getting into and left. And the ones that stayed tended to have previous problems with their state medical boards. And the folks who really ran these pharmacies were people who were always on the, had one foot on the edge of the law. And basically people came and paid cash and walked out with their pills. And that was another way in which pills started flooding these communities. Okay, back to this one. Just going to go back to this just to get the timeline So 2010, you can see, I hope you can see, but the heroin is the red line. And that started to bump up in 2010. So why is that? Well, as I said, heroin had been percolating, in these communities all along, and it was pretty cheap. But around 2010, the painkillers became harder to get. And I guess if you had a choice between painkillers, which are labeled, you know what the dosage is, you know what you're getting, you know it's pharmaceutically pure, I'd pick that over heroin too. But when they became harder to get and more expensive for various reasons, one, the DEA, the law enforcement and the DEA were really cracking down on pill mills. Doctors were starting to get the idea that we're prescribing too much. PDMPs, which have been around for decades in various forms, were finally starting to get more rigorous. That's prescription drug monitoring programs. OxyContin was reformulated so that it was much harder to chop up and inject or snort, which was a common way in which it was abused. So when these things were converging in 2010, and heroin was around, so some people switched to heroin. What do you do when your pills aren't available? You do several things. You find a substitute, and heroin was a substitute. Now, I have to say that the studies I've seen on this show that the percentage of people migrating from pill abuse slash addiction to heroin is actually kind of small on a percentage basis. It wasn't more than 5%. But remember, this is a death. These are deaths. So it was disproportionately deadly, people who aren't used to it. So you switch to something cheaper and more available, which is heroin. You quit, and people do quit on their own. Dr. Gene Heyman, I don't know if he's here yet, and hopefully he'll be here by the time we get into Q&A, but he's an expert on spontaneous recovery, which is a really interesting phenomenon of people, even with very severe addictions, managing to stop on their own. And also a lot of people cannot. So anyway, you can't get your pills. What do? You decide, I'm stopping, or I'm moving on to another drug, or I'm stretching the pills I have by adding more alcohol, adding more benzos, or you go into treatment if that's available, and that's a big if, depending on where you live, or I'm just going to continue to use drugs because I don't want to quit. And that's also not an uncommon decision that people make. Okay, finally now to sort of the end of this continuum, we get to around 2014, 13, you can see fentanyl just taking off. If anyone knows in the Q&A, I'd love to know why it started taking off then, but it did. And you saw the potency. One of the most vivid reports I read was everyone everywhere has Narcan these days, high school teachers, librarians. The librarians in the Philadelphia library, that they could tell when someone was shooting up in the bathroom whether they were using heroin or fentanyl, because if it was heroin, they kind of heard a person sliding down the door and the wall and then there'd be a thud. But if it was fentanyl, it was like an immediate thud, just much more fast acting, and often requiring many, many administrations of Narcan to reverse. Okay, so these are the patterns, and again, pills, the people who are succumbing to pills, plus, again, just these are identified as opioid painkiller related, heroin related, fentanyl related, but as I said, people often take a variety of things at the same time. But pills are mainly used by older folks, and they are most of the deaths from pills. These are folks living in rural areas, Rust Belt, Appalachia, places where mining, milling, textiles, steel farming, and hard labor. You could see why these people were prescribed these medications to begin with, because they did have chronic pain. Mainly white, and it's even true in, it's less true, in the inner city. Like at my methadone clinic, I wouldn't even know there was an opioid epidemic, because the average age is 57. Almost everyone, the majority, I think 80% of folks are African American. They all started in their teens. They probably started with needles, and they started with heroin. That's inner city. The incidence of opioid addiction in DC is probably low, and I define incidence as new cases. Not many new cases, but a lot of deaths because now they're taking fentanyl. But so again, interesting geographical distribution. People who are single, never married, have a high school degree or less are also more likely to overdose. So if there's general agreement, I alluded to this before, so there's pretty general agreement that overprescribing spurred the crisis, but it's not driving it now. But when it was driving it, so how did that work? Well, I guess I alluded to the fact by mentioning Marcia Angel or her piece, that the risk is not so great. In fact, it's quite small for the average person going into the doctor, getting the classic wisdom tooth extraction or sprained ankle. And I'm not saying the doctor doesn't give you too much, but I'm just saying that most people have a lot left over and it goes in the medicine chest. And that's really the problem. It's, I'm actually seeing the time's already getting short, so I can provide these data afterwards, but there's a modest literature showing the rates of addiction with even chronic pain administration, opioid administration for chronic pain, although, of course, the longer anyone is exposed to any addictive medication, the higher the chances of ultimately becoming addicted, but they're still quite low. A Cochrane study found less than 1% in non-cancer intractable pain, and a New England Journal of Medicine review, and Cochrane's of all reviews, of course, and the New England Journal 2 years ago by Nora Volkow and others said maximum of about 8%. It's hard to get a number, and studies vary, but these reviews tend to find pretty low rates of addiction. And when you look in that subpopulation, who are these folks, though, who are starting to take too much of their Percocet and going back to the doctor, even though the pain's gone, and saying, I really still need it, they tend to be people who have had prior problems with drugs or alcohol, or are depressed, or anxious, have some sort of psychiatric diagnosis, or what I would call, this is not a psychiatric diagnosis, but I would say demoralization. But that's a subgroup of people who are vulnerable to becoming addicted. And when you look at all the pills that are being used in the country, the majority of let me back up. When you look at all the misused pills, I have to say I hate that word, because it's anything from, you taking your wife's sleeping pill because you just can't sleep, to, you're selling them on the street because you need more money to buy heroin or something like that, because you'll get more money for your pills. You'll get probably $1 a milligram for your pills. And to being, addicted, completely addicted. So it's a sort of an unhelpful designation, but it's the one used now by the feds. Anyway, but the vast majority of misused pills in the country are not being misused by patients. They're being misused by people who, is this the medicine chest one? No. Sorry about that. That is, but that's not where I wanted to go yet. Even though prescribing is starting to go down, the vast majority of pills that were abused and still are abused are by people who, frankly, do get them out of medicine chests, and or pill mills, which are still around, although they certainly are fewer in number. Here's a slide that I hope that print isn't too small, but the important part of this is sources of pain relievers. This is, I'm sure it was probably gotten from the NSDUH, but it's a Senate report. So it shows that 20% of misused, they use the word abusers, but misused opioids, only 20% are from a doctor. And that's not even saying if those 20% were really medically indicated. Even if let's assume they were, that's still a significant minority. The green shows that most of this was gotten from most of the pills were obtained from a friend or a relative. You get the idea. The blue is a dealer or a stranger from the internet. And in fact, that's where most of the fentanyl is coming from, the internet, not for individual use, but for people who are packaging this stuff. So that's an important point that I wanted to get across, because the title of this talk was Early Lessons, and I think that's one of the lessons we're learning is that, you know, there's a subgroup of people who are vulnerable. And now there's a, I don't know, hysteria seems too strong a word, but like this very, very aggressive effort now to limit prescribing in terms of the laws. About half of all states have laws about where doctors can't prescribe for an acute problem, for a new onset problem. You know, more than 3 to 7 days or 10 days may be the limit, depending on what state you're in. CVS has a rule. CVS is I think it's the biggest benefit manager, or the second biggest. And Express Scripts, between the two of them, they're probably 99% of the market. And CMS is thinking of these limits. I think the limits make sense in terms of, again, restricting the amount of opioids out in the world, but they don't make sense in terms of protecting the patient who's going to be taking them for his wisdom tooth, because he's probably not going to abuse that. And a very pernicious downside to all this is come about, and it's really unfortunate because everyone is clearly trying to do the right thing, but with all this worry about, well, we can't prescribe too much, it's sort of migrated into the treatment of chronic pain patients, which is a totally different population. And there are reports right and left of, and soon there is a registry keeping track of the suicides of people whose doctors have read the CDC, the 2016 CDC guidelines on prescribing opioids, which some people here may disagree with me, but I think are within the realm of reason. And they're guidelines anyway, they're not mandates, but they're read by so many docs who are so, and understandably, no one wants a DEA agent at their door. So everybody's afraid of everyone else here. And so, in fact, this summer I got an email from a woman who, she was a doctor herself, an orthopedic surgeon, who had something called interstitial cystitis. And if any of you know what that is, you're already cringing, because it is like the most torturous bladder inflammation. I think it's an autoimmune problem. But I don't know if even the pathophysiology is that well known, but it is excruciating. And she developed it in her late 20s during her residency. And finally, after some experimentation with her doctors, it turned out that methadone worked the best. So for 36 years, she's been an orthopedic surgeon, for heaven's sakes, a very functional orthopedic surgeon on methadone. And one day in July, she walks into her doctor's office, and the doctor says, "I'm not doing this anymore." What? I'm not doing this anymore. And basically walks out. But I've had her tell me the story 3 times. I mean, she just walked out. This doctor, her name is Vicki Ratner, and I've written about her, and she doesn't even mind using her real name. She thinks that the doctor had misread the CDC guidelines, but whatever. Again, there's this climate of paranoia, and luckily, Dr. Ratner was able to find another doctor, but she is a doctor, and she lived around Stanford, you know, in Palo Alto. So could you imagine someone, you know, who doesn't know how to negotiate the system, and there isn't a real quality medical center nearby? She said the doctor didn't even give her enough pills, you know, to hold her over. She had some, and of course she took, you know, half her dose and all this. I mean, a nightmare, but she was saved, and people aren't being saved. It's a disaster situation, and Congress people are being called about it. Anyway, that's a very important unintended consequence of all this that I wanted to get out. Now, I'm moving on. I have 18 minutes and a lot to cover still. So, I don't know how many folks here have read Dreamland. It's very interesting. I mean, I'd especially recommend it for the story of how the Mexican black tar heroin came here. But I think it's such a great sociological, it's not that theoretical, so I guess it's more descriptive, but just great reporting on how OxyContin and other pills actually financed almost an economy, a barter economy within some of these communities. That's how much it took over the culture of these places. So this is an ad for the book. Let me get back to a point I made earlier, that who are the people who are abusing drugs, who are abusing the painkillers? To me, that's really important. Now, the slide that showed, I didn't show you the slide, but one of the other facts about these folks who are abusing painkillers, misusing, abusing, not prescribed them by doctors for their own pain problems. Another very important characteristic is that the vast majority, between 70 and 80%, were already drug involved before, whether it was alcohol, inhalants, sedatives, marijuana, benzodiazepines. Now I say drug involved because I don't know what the heck the word misuse means, and that's the way NSDUH presents the data. But the point is, 77% of them had familiarity with these drugs before, and other surveys have shown more than familiarity. I mean, not just I smoked marijuana once, but a fair amount of use. Well, what is that? Tells you something. To me, that says even if these people weren't addicted to these other substances before, that they meant something to them. In other words, that they were using them for a reason, which was to change their mental state and try to alter their inner landscape in a way. And for people who are in distress, there's nothing better than opioids. I mean, everyone has their so-called drug of choice, but a lot of people think opioids are just phenomenal. And they are. I mean, why would they be named after the god of dreams? I mean, people talk about depressants and stimulants. Well, I think there should be a new class of medication called obliviants, and that's what opioids are so good at. Now, it doesn't mean that in fact, most people are not spending all day either in withdrawal or nodding out. People are busy. People are also working. They don't want to be perpetually in oblivion. They just want to get through their day with a lot less pain. And that gets you back to hillbillyology. And you've heard all the fallout in these communities. The foster care systems are overrun, the EMT costs from the Narcan, the effect of kids on seeing your parents overdose or die, or just being neglected, which is bad enough. And then, actually, we have, it's interesting to think of where do the economic causes and the cultural causes, how do they interact? And I know that's an eternal tension between, politically speaking, on the right and the left. The left tends to focus more on economic causes of decline, or social decline. The right may focus more on cultural. I don't even know what to think, except that they're both relevant and they certainly interact. I mean, you have people who are not working because they're on opioids, or maybe they're on opioids because they're not working. But we do know that in 2015, nearly 22% of people aged 20 to 64, this is men, I should say, 22% of men aged 20 to 64, able-bodied men, were not engaged in paid work of any kind. I mean, this transcends opioids. This is a culture, the national serious phenomenon. But again, that points less to the economy and more, perhaps, to cultural reasons. I can't say anything in more depth except to just raise these as very important contributors. And while we call addiction a medical problem, it seems more medical at the beginning because we withdraw people. We use that's medical. And we obviously have three excellent medications available, good old methadone, buprenorphine, and naltrexone. But the farther out a person gets in recovery, the larger the scope gets. And it gets more psychological, it gets more social, and depending on where you live, it can get more psychological, more environmental. But you can also be a kid with two loving, wonderful parents who are always attentive. You're doing great in school. You're the captain of the whatever, and yet we know teens who seem to have everything who have problems too. And that gets, again, to that deeper issue that transcends how much money you have and where you grow up, which is why people are drawn to these substances. And it's because of, I've always been a big believer in the self-medication, self-regulation point of medication. So let me, okay. So another lesson, I'm going to get back to that in a minute. I don't really have much time. I may have to come out in Q&A. So I guess in some ways, when talking about supply reduction, when I talked about fentanyl in China and doctors prescribing and all this, and I started to get into demand reduction, which is why do people want to use these things? So I mentioned some reasons that are really pretty encompassing, but it doesn't mean that, again, we can't address them through clinical means, even though I do think some of the solutions really are on a very large, daunting scale and a massive social project about bringing prosperity back and hope. And J.D. Vance always says that Middletown, Ohio, which is where he lived, was hemorrhaging jobs and hope. So yeah, that was a great series. I'm sure you all saw that in The New Yorker by Margaret Talbot. So what do you do in the short term? Well, you know all this. We do Narcan. We have recovery coaches and ERs, because I think a lot of policymakers and probably a lot of people who aren't too familiar with addiction were kind of surprised at how hard it was to engage people. I mean, I think a lot of people thought, well, you perform this Lazarus-like procedure and people wake up and say, I want treatment. And some of them do, there's no question, but a lot of them say, get the hell away from me, and they're running down the street because now they're in withdrawal and they've got to do something about that. But let's say they get to the emergency room. Well, how many walk out of the emergency room? Or let's say they stay in the emergency room, and somebody holds their little hand and walks them over to a treatment program. Well, how many stay in the treatment program? Well, in general, not many. That's not true. The dropout rate, though, is impressive. It's between, depending on which study you read and what therapy it is, but over half are gone by the end of they don't even make it through a whole year, and you pretty much need to be in a treatment program for at least a year to get on the pathway to recovery. So that's a big problem, engagement, and that's my personal interest in how to do that, how to engage people. But it also goes to a question about why addiction is so hard. And this sort of gets me back to what I was alluding to before about why people are using. Engagement is hard, and this is stipulating the resources are there, and in a lot of places they're not. But engagement is so hard because people are really ambivalent about giving up their drugs, and for the reasons I mentioned before. Even though there are terrible losses that they've suffered, someone who's, I often read this, this line from someone say, I never met anyone who wanted to be a drug addict. Well, that's not what people want anyway. No one wants to be a drug addict, no one wants to be poor, and no one wants to be obese. These are conditions that come on incrementally. And you don't want to be, as I said, an addict, but you want the relief that the drug brings in the short term. People who use drugs are incredibly steep discounters. They want relief now as opposed to relief later or reward later. Some of that is probably a function of having been addicted for a while, and arguably, although I don't have data for this, and it's a hypothesis, that people who are drawn to drugs have short time horizons to begin with. But in any case, the point is that no one wants to be an addict, but they want the relief that comes with it, and they want it now, and that's what they want. And so then you also, and why do they want that? Well, I mentioned that before. Some people just, even the most privileged among us, have always just had a gnawing sense of inadequacy, a sense of just never feeling right in their skin. I mean, these are vague things. A sense of self-loathing. That's, if you read addiction memoirs, and there are millions of them, but that's one of the most powerful sentiments that come across. I just read one by Art Pepper, who was a jazz musician, and he's a beautiful writer, and my God, he just writes about that so poignantly, and that is huge. So that, you could argue, and then there are people who live in places that are hemorrhaging hope and, hope and jobs. But no matter what's driving it, it is an effort it's a great numbing agent to cope. And then you've got, so that's your first layer. Then you've got a whole secondary layer of all the problems that have come up, all the trust you've lost, all the jobs you've blown, all the relationships you've decimated, your health. And, when you think about it, without the drug, it's pretty raw. So it's not that much of a surprise that people keep returning to it. Many people, not all. In fact, I don't think we talk enough about the people who do well. A lot of people do well. As I mentioned, people do stop on their own. The sociological literature in the 80s has so many good books about spontaneous recovery. People do stop. But, as I said, a lot don't, and they go through hell before they stop. And why they stopped after that overdose, but not that overdose, is a very interesting question. But it's sort of the alchemy of your life. What else is going on? When you see hope, when you don't? Who else is around you? What's in the environment? All these kinds of things. Well, I see I have 6 minutes left, so I'm going to just close with what I think should be done, which is a little more than what the president said last night. And he did mention opioids, which is great. I do think this is one of those problems you could throw money at, to be honest. I think that localities know a lot of what they need, and I think that federal money should be much more forthcoming, and maybe it will be, I don't know. I do have a lot of faith in the new, there's a new position called the Assistant Secretary of Mental Health and Substance Abuse, run by a woman named Eleanor McCants-Katz, who used to be the head of mental health and substance abuse in Rhode Island, and she is first rate, and there has to be oversight, obviously, of federal money, and I think her agency under her direction could do a very good job of that. How do you get more patients engaged? Well, I know that there are recovery coaches. I'm sure people are writing up the results of those, but I really haven't seen many yet. I don't know how effective they are. Intuitively, they sound good. But I am a huge fan of contingency management, which is basically, I guess you would call it, the old word for it was a token economy, where you reward people and you do it swiftly and certainly. So they give a clean urine, you've seen the literature is massive. People get movie tickets, people get Walmart, credit cards, whatever. For reaching some milestone, and also for immediate progress, because Behavior 101, if you want to shape behavior, you have to reward it and sanction it, in a very timely way. This is a time where we could, as I mentioned, the literature is huge, but it's rarely used in treatment programs, except methadone, where we can actually give you more take-homes or not. But it's rarely used in treatment programs, I don't think because anyone's against it, but because who has the money for that? You can barely keep the clinic running, and who's going to buy the movie tickets, and that's going to add up. So we know we have great proof of concept, but it's not been used much. But I love to see, whenever I get approached by some rich person who wants to do something, I always say, why don't you just establish a fund for incentives, and then programs can apply and use them. In any case, so I think that might be of some help in these programs. I also, I'll close by saying I think the criminal justice system has a big role to play. And frankly, every time I hear the phrase, we can't arrest our way out of this, I want to scream, because the proper sentence is we can't incarcerate our way out of this. if people commit a crime, and I mean a crime, I don't mean the crime of being an addict. In fact, that's not even a crime. The Supreme Court determined that in 1975. But shoplifting and, burglary, things like that, and they get arrested, there are drug courts, there are diversionary programs we can use. And at their best, they drop the charges, when a person completes it, because you want them to have a fresh start. You don't want them saddled with a criminal record, unless it was a huge violent crime, in which case they're not even eligible for diversion at all. And this is the first time, you've all heard of drug courts, of course, and this is the first time we've ever had the supervision of the judge, there are the sanctions of the drug courts and the incentives, and I still think if adding medication, the anti-addiction medications to that should be an incredible synergy. And we'll see, there aren't that many drug courts using medication, although the use of medications through the criminal justice system is getting better, certainly has a long way to go. I'm really looking forward to those data. There are some drug courts that are using medication. One would think it would really make a quantitative difference in outcome, but I hope. So that's I'll summarize my lessons, because that was the title of my talk. One is that the crisis is no longer driven by pills. It's driven by fentanyl and heroin, especially if you're talking about deaths. We are prescribing fewer pills. If you recall that slide, admittedly, it wasn't that impressive. It was a drop of, I think, maybe 13% over the last 3 years. I sort of worry maybe the pendulum will swing too far in the other direction, where we're really abandoning chronic pain patients, and now there's a phrase called pain refugees. I mean, doctors who are just too afraid to treat these folks because they're afraid of getting flagged by the DEA, and it's really quite a problem. But I do think the middle ground at some point will be achieved. I hope I've convinced you that at least think twice when you hear what you'll read in the paper almost every day, which is that someone got 3 Percocet for a dislocated shoulder and then they were heroin addicts the next week. It doesn't work that way. I mentioned the unintended consequences of pain patients, how hard it is to rethink engagement. And my last topic, which I'm not going to go into because I have no time, is, but I touched on it, is rethinking addiction in terms of being more complicated than we think of it. I think we tend to, I understand why we medicalize it, because if my choice is criminalizing it, I'm going to pick medicalizing it. If my choice is moralizing it, I'm going to pick medical. Those are my 2 choices. I'm going to pick medicalizing it. But we've got to give much more thought to the idea that this is a condition that responds to incentives. Other brain diseases do not respond to incentives. You can't incentivize a patient with Alzheimer's to not have their memory deteriorate. And this is a condition that, unlike anything else in medicine, I think you can say this, it makes sense to ask a person why they have it. Why do you use drugs? It doesn't make sense to ask people why they have other conditions. Anyway, thank you very much. Yes.
So I was very pleased to hear you talk about the concerns of people who are in pain, who aren't being adequately treated. As somebody whose wife has had 3 joint replacements, I can tell you that an abundance of opioids works really well to enable somebody to rehabilitate. So, no, what I was saying is that I'm glad that you talked about undertreating pain, because I think that is going to be a big problem, particularly because of the fear that doctors have, and often that fear is really not all that justified, that the DEA isn't under every door. But what I wanted to ask you about was what is the crisis? Is the crisis people using opiates, or is the crisis people dying from opiates? Yeah. I'm not sure that if people weren't dying from it, that anybody would have noticed the crisis.
Something. I do think you're...
And so let me just follow that up with, if the problem is people dying, and what we want to do is keep people from dying, what's actually wrong with being an opiate addict? You talked about your friend who was a methadone addict because of her medical condition, and that she worked fine, and she was an orthopedic surgeon, and she took methadone every day, and she did her orthopedic surgery. And you talked about other people who, they don't want to be high all the time.
Right. Well, okay, I'm ready.
Yeah, so I'm saying,
All right.
why not just give addicts opiates?
Well, first, I have to make a distinction between dependence and addiction. Your wife, without question, is dependent. I don't know what.
She wasn't dependent. She just needed it.
No, that is dependent. Let me define it. Yeah, I would be dependent if I took Percocet for 2 weeks every day around the clock. I mean, there are a lot of individual variations. I have a patient. I almost don't believe him, but he used everything, and he said he used heroin every day and didn't feel that he was addicted for many months. But the point is, there's significant variation. I'm talking about dependence. I'm sorry, I just mixed up my terms. Dependence just means that you are physiologically adapted to, and that if I stop it abruptly, you will experience withdrawal syndrome. Most addicts will have a withdrawal syndrome as well. I can imagine they wouldn't, but it doesn't work the other way. You can have that withdrawal without being an addict. It's just a result of constant exposure. And sometimes there's development of tolerance. I mean, that's an interesting phenomenon, why patients can be on methadone dose of 80 for a year or 3 years or 10 years with no shift, and other people have to escalate a lot. I gather maybe your wife her tolerance is steady, just like this woman, she doesn't have to keep upping her dose to get the same relief. If she were, addiction is a little different. Addiction means that the word is people often say compulsion, but a very strong urge to use, and typically to alter a mental state. Now, the classic definition of addiction is excessive use of a substance with a strong desire to use, a difficulty stopping, and in spite of negative consequences. That sort of covers addiction. But that doesn't sound like, the situation you're talking about, which is someone, and the short answer is yes, people can be maintained as patients, and I should say people can be maintained as addicts. If you have a supply of this I mean, this is terribly politically incorrect. It's not politically incorrect, it's just something that if you have a reliable supply of medication and your tolerance is not escalating quickly, because then if it is, you need more, and then eventually you have to start resorting to illegal activities to get more drugs, to get more money to buy more drugs. But there are people who are maintained on if they have a supply and if they have a clean supply and they are maintained and they are addicts. They would call themselves addicts, and they do fit that definition, except I suppose for the negative consequences because they're managing their lives well. Again, in the addiction memoirs, you'll read a lot about that, especially in terms of phases of an addiction career, where people maintained and were productive. A lot of artists, for a long time. Now you get a hold of fentanyl, that ruins everything. Or your supply is no longer available, or it's not as pure, and that's when problems often start. But from a pure physiological standpoint, I mean, opioids are going to constipate you. And if you take too much, you'll stop breathing. That's a problem. But that's true. So. But there's a difference between a patient maintained on an opioid and doing well. I'm not saying that all patients who are on opioids needed to be on them. Some do, no question. If early in their chronic illness they were started on a different route of therapy, maybe they could have avoided opioids altogether or maintained on a much lower dose. That's possible. But when it's 10 and 20 years out, and then you have all kinds of physiological changes it's not like someone who's on it for a week. You just can't whip somebody off that. You can talk to them about, would you like to be on a lower dose? We're trying to bring people down. And a lot of people say, I don't even want to be on so many opioids. The opposite of your, wife, because they feel too sedated. Or, frankly, the constipation can be a huge problem for people. Or sometimes people even forget they took their dose and, they can't rely on their memory that well. There are people who even want to come down. The issue really is taking people down non-consensually. And if they're doing well, I just can't, I don't see how that's medically defensible. But yes, we have to invest more in alternative pain therapies. I don't mean alternative medicine necessarily, but I mean other kinds of pain therapies. But when a person's doing well and they're using and they keep their drugs in a place, when you're get take-homes for methadone, you have to put in a lockbox. I mean, you have to come in with your thing with the key. It's Fort Knox. No one can get into it. You've got to keep this stuff safe. That's what realtors tell people. If you have people coming through your house, get the stuff out of your medicines. You've heard all this, right? There are some towns where they don't even announce if someone died from cancer in a home hospice situation because that's a red flag. Wow, there are a lot of pills there. So, you've got to protect these pills as well. So it's sort of all true. Almost every positive and negative consequence of being maintained on opioids chronically, it could be true depending on the person and the circumstance. Yes, this lady. Can you get that to her? I don't know if you need a microphone.
I'm sorry, I actually have a question.
Oh, I thought you were
Yes,
the
yes.
microphone.
Hi, Matt Schultz from Boston University Questrom School of Business in Health Sector Management. I thought your take on drug courts, particularly with some of their effectiveness or maybe the uncertainty of their effectiveness, was interesting. Over the summer, there was a New York Times article, an NPR article about the conflicts with drug courts prescribing extended release naltrexone, and today the Globe reported about some of the ineffectiveness with some of the treatment options that ER doctors have been trying to engage ER patients when they have come into.
I saw that.
Sorry?
I saw that, yeah.
And I was just wondering, do you think there's a moral quandary with, criminal justice systems prescribing without the opportunity for doctors to step in and prescribe the correct type of medically assisted treatment?
Yeah, although I think you may have misinterpreted me. I wasn't questioning the outcomes of drug courts. Did you think I said that? I think drug courts are a good innovation, but with the medication, I know that's been a debate. No, I don't think a judge can order a medication, say you have to be on this or that medication. In fact, I don't think a judge should order a person to be on anything if they can comply with the requirements of the program. But I certainly don't see, judges prescribing for sure. And you can easily imagine, a trajectory. If you've got a really, really heavy addiction, buprenorphine might not even hold you. So you go on methadone first, then you gradually, get down to 30, where you can switch over to buprenorphine. It's going to switch, and then whatever, you could stay on that for a while. You could switch to naltrexone, a blocker, after that. Or some people don't need any med. I guess the take-home message is that all these things need to be available. Patients need to be educated about all their pros and cons. But a one size is such a cliche, but the old one size fits all thing is always risky.
I'd like to commend you for the remarks that you made, both on the question of the larger picture about the crisis, because I do believe that it is a disease of despair. I also was pleased that you addressed the chronic pain that many patients have. I work with a doctor who deals with patients who do have chronic pain and hemoglobinopathies. From the practical standpoint, I hope it's not a problem that I bring up something that is very much on my mind, because I have a relative who works here in Boston with overdose recovery. And what they're finding is domestically there's a much more potent form of fentanyl produced here domestically on the streets, and that the potency is quite fierce to the degree that their ability to resuscitate a patient even after administering the Narcan or whatever that drug is, it can be upwards to 7 minutes before the person actually is awake and recovered.
Wow.
So this has become a very
And then an
big-
hour until they're not recovered.
Yeah. And then again, after they've taken that drug, I mean, the problem is
Well,
they
what
might
I'm
go take
yes,
more
that's
drugs.
true. But what I mean is, if they don't, then Narcan wears off, and then if you've taken a lot of opioids, it's still in there, and it can just come back, and you can become unconscious again. But did you ask? I'm sorry, I could have cut you off. Did you have a? Well, I mean, I mean the one obvious answer, of course, is more treatment. Although I don't know the state of affairs in Boston, but I can't imagine that that's a lack, because obviously you want to offer people another option. But and this brings us to where's Brianna? The whole safe safe consumption, safe supervised. I hear the phrase different all the time. Which is the preferred now? Supervised consumption or injection? Okay. Where, yes, I mean, I almost think, what can you're familiar with that concept, right? In fact, there was a little demonstration. Someone said, there's a demonstration outside, and I thought, oh, a protest. It was just showing how it worked. But I almost don't see how you cannot think in terms of that kind of an intervention when there is something that's so deadly. I suppose I'll just give my soapbox response to this, which is I'll start from up the 10,000-foot view, which is I really believe in local control. So, and I realize there's a lot of debate about this issue, but basically, if a community wants to try something, I think they should have that opportunity to do that. They think that's what they need. I think that should be taken very seriously. I also think if we proceed, that it has to be studied, and has to be studied independently, that people from BU don't study it or study parts of it, but the ultimate evaluation is done by Harvard, RTI, whatever, Rand, I don't know if they do that stuff these days, but anyway, some independent evaluator has to, because it won't be taken. If you get great results, then they're always going to be tarnished because they're done by the person whose project it is. You just can't do that, especially for something as sensitive as this. So those are my large bore views on it. And the other is, I just hope that, and I'm sure you guys, who's ever invested in this, in safe injection facilities, it really, really pumps up here's a treatment program you can go to. Here's a person who was in that treatment program, and this is what he's or she is doing now. Here are the things we can offer you. Try to use it. And I know I'm not telling you anything you don't know. This is one of the justifications, that it may be a pathway into more conventional recovery. And I suppose, and maybe this finally getting to the really controversial part, I don't know, but I'm all for harm reduction. But to me, there's aspirational harm reduction, and there's what I would call sustainable harm reduction. The latter is just we keep people alive, which is not nothing, but that's what we do. We're just here. If you're alive, we're happy. And as I said, that is not nothing, so I guess I shouldn't sound flippant. I don't mean to, but there's more to it than that. And, I mean, that's where sort of the meet people where they're whatever, that's fine, you meet them there, but how long do you want to stay there? And, I mean, there is no answer, but I was watching this program about LEAD, and I can't remember what the acronym stands for, but it's LEAD. I think the E is Law Enforcement Alternatives to something, Anyway, this was a PBS show. I think it was 2 years ago, and I was boiling watching this thing. And so it was 2 hours, and they devoted, I think, a whole half hour to this woman, very attractive young woman, who had a heroin problem on the streets of Seattle. And she was, instead of being arrested for, I don't know if it was prostitution or whatever, stealing, I think, they said, we'll just bring you over to the lead program, and here's your social worker. So she met with the social worker, who dutifully, this woman was so earnest, and she really wanted to help, and here are housing options, and here's treatment, and here's birth control, and here's this, and here's that. And I think the girl's name was Kristen, and she basically said what she was there for was some sort of entitlement. She could get some sort of income support. She didn't take advantage of any of these other things. She was out on the street for a year. The social workers running around looking for her in the freezing, to give her a hug. She's in the ICU twice. This woman ends up, a 22-year-old in the ICU is a drug addict, so obviously she had sepsis or endocarditis or something. If she were any older, she'd probably be dead. It's a lot on a body to do that, 2 times in 3 months in an ICU. Is that the kind of harm reduction you want? I don't know. It's like, how much do you stand by and watch people destroy themselves? Now, an injection center, I understand, is different. If I ran one, I would like to see, I know from the methadone clinic, I have all these folks who don't work and they don't this and they don't that, but they're really good at least one thing. They know how to fix things. They know exactly how you do house painting. They know plumbing. They know some electrical stuff. Not so much, but enough. Or they're great bakers, or they're great at something. And so have them be busy. Have people be busy, because being bored and being not productive is the worst thing. It's a recipe for relapse. And plus, it's demoralizing. And people want to be busy. They want to be productive. They want to be appreciated for what they can do. And if their job, if they're on some disability or some, they get some funds for something, still, there's work for you to do here. Help maintain the clinic, and we'll help you and all this. That's what just that philosophy of not just being a place where people can just walk in and walk out and maintain a marginal lifestyle. I understand at the beginning you might have to put up with that. I don't know. I'm not running this thing, and I'm sure it's really hard to do, but I hope that philosophy would sort of be a little more, would be more prominent than it might be. No? Oh, wait, there's one more. Yeah, behind you.
Hi. Do you think there's a role by drug companies to invest more in solutions like naltrexone? And if there is a role, how are they going to get more interested in it?
How is a drug company? If they see a buck, are you kidding?
Well, no, it's.
Are you a pharmaceutical guy?
Yes.
Oh no. Well, then you know how to motivate you. I remember people saying no one wants to invest in addiction medications because it's addicts and they're stigmatized. No, that's not true. They're worried at one time that they wouldn't make any money. Look at HIV, for heaven's sakes. Talk about a stigmatized population. Double, gay at the time. We're talking a while ago, but both gay and HIV drug users. And that was a huge pharmaceutical effort. I know government played a big role as well, but it's whether there's profit to be made. And I don't mean that cynically. I think great, let everybody benefit.
Please join me in thanking Dr. Satel.